Good evening, participants. Thank you for joining Shield Connect. Today we have a reputed doctor from Dibrugarh, Dr. Deepak Kumar Niyog, and sir is going to take topic menopause management. So before we start with session, let me give a brief introduction of our speaker for the day. So, Dr. D.K. Newok, sir has 25 years of experience in field of obstetrics and gynecology. Sir has 15 years experience in the field of minimally invasive gynecological surgery. Sir is first in Northeast of doing laparoscopic radical hysterectomies in cases of carcinoma cervix. Sir has experience of doing almost all varieties of gynecological surgeries by laparoscopically, and sir is a qualified MBBS DGO. Sir is senior consultant obstetrician and gynecologist, minimally invasive gynecological surgeon. Sir has attended as operating guest faculty in national and regional endoscopic workshops, and sir has presented many talks in national and regional conferences as a guest faculty. So I welcome Dr. DK Niyok. Sir, we are glad to have you on our platform, and I will hand over the session to you, sir. And I hand over to you, sir. Thank you so much, sir.
Thank you very much. At the outset, I like to thank you, Shield Healthcare, to giving me this opportunity to speak a very important topic of menopause today evening. Good evening to all my delegates. So it is not a new topic, but a very important topic because of increasing life expectancy in our female population. The importance of menopause, talking of menopause is very essential in every point of time. So I like to share my screen here. My today's topic is menopause and its management. So what is menopause? Menopause is a normal natural event defined as a final menstrual period, FMP, confirmed after 1 year of no menstrual bleeding. It represents the paramount cessation, permanent cessation of menses resulting from loss of ovarian follicular function, usually due to aging. Naturally, it is spontaneously, average age is around 50 years, 51 years. Prematurely from medical interventions, as for example, bilateral oophorectomy, chemotherapy, at any time from impaired ovarian function, premature ovarian failure or insufficiency. Now, what is the straw staging system? Straw divided women's life into three categories, the three stages. There's reproductive, menstrual, menopausal transition, and postmenopause. And menstrual cycle during reproductive is variable to regular or regular. And in menopausal transition, this variability may be more than 7 days when it is perimenopausal age, and if it is more than 60 days or skip 2 cycles, maybe in menopausal transition. And in postmenopausal period, there will not be any menstruation. Endocrinologically and reproductive age, there is normal FSH or maybe there is increased FSH. But in menstrual transition, there is increased AMH, FSH or AMH. And in postmenopausal, there is high rise of FSH. Age at menopause has remained constant while life expectancy has increased. That is why this topic is very important, because after menopause, most of the women live for a long time. So you can see the curve. In 1919, the life expectancy, it is increasing day by day. In today's, this is the scenario. So serum hormone levels at menopause, that is, there is a decreased circulating estrogen. This ratio of estrogen and androgen is decreased. Sex hormone binding globulin secretion is decreased. There's increased peripheral aromatization of dihydroepiandrosterone to estrone. There is reversal of E2 to estrone ratio, E2 to E1 ratio, and no, there is no significant change in testosterone level. Now, these are the estrogen receptors where it is located in a body. That is brain, breast, eye, genitourinary tract, heart, blood vessels, liver, ovaries, skeleton, skin, and hair. And these are the sites where the estrogen receptors are located, and after menopause, these organs are affected. Now, what are the type of estrogen receptors? There are two types of estrogen receptors been identified. One is alpha and beta. Other is beta. Now, estrogen receptor distribution, alpha and beta in CNS, blood vessels, bone, heart, breast, ovary, uterus, testis, and prostate. And in alpha receptors, predominantly in liver. And beta receptors are located in lung, kidney, bladder, and intestine. Now, estrogen has many complex beneficial and deleterious effects on the body. Effect of estrogen at various sites in the body. That is, according to this, I am just going to these organs, bones. There is increased deposits of calcium into bone. Then clinical effect leads to there is increased bone density, and in absence, it causes osteoporosis. Coming to brain, it blocks the release of ovarian estrogen, and there is no effect in clinical effect because of estrogen. But in postmenopausal period, there is hot flush, sleep disturbance, mood changes, problem with memory, Alzheimer's disease. In breast, it stimulates growth of the breast tissue, and clinical effect is bigger the breast, increased risk of breast cancer, increased sensitivity of breast, increased risk of breast, and there is in postmenopause there is breast is become smaller. In a clotting system, there is increased risk of blood clot, and there is no changes in clotting after menopause. There is when there is estrogen is withdrawn. And blood fats, there is increased HDL, decreased LDL, and decreased cholesterol. And after menopause, there is these things are reversed. There is decreased HDL, increased LDL, and increased cholesterol. In skin, there is increased fat deposition in skin. Skin becomes softer, and after menopause, skin becomes thinner, liver spots, and dry skin. In uterus, there is increased stimulation of uterine lining and muscles, heavier cycles, increased risk of uterine cancer, and after menopause, there is no period at all. In vagina, there is increased thickening of skin, better blood supply to the tissue, and as a result, there is vaginal discharge, feeling of pelvic congestion. And in absence of estrogen after menopause, there is dryness, vaginal infections, painful sex, incontinence of urine, and pelvic weakness. Estrogen loss and manifestations of health risks over the time. There are short-term symptoms and long-term diseases, development of sequential diseases. Number one, hot flush. Number two, mood, sleep, and acute cognitive changes, urogenital symptoms and skin changes, and there is cardiovascular diseases, and finally osteoporosis and cognitive decline, Alzheimer's disease. What is the physiology? And each ovary has a certain number of oocytes from birth, which steadily decrease until we are approximately 50 years of old, when the stock becomes exhausted. During the perimenopausal follicular activity fails, estrogen levels decreases and pituitary gland produces increased amount of LH and FSH due to negative feedback. Cycles become anovulatory, follicular development stops, the endometrium is no longer stimulated, and amenorrhea occurs. A natural menopause occurs because as you get older, your ovaries stop producing eggs and makes less of the main female hormones, estrogen. The symptoms you are experiencing are due to low level of estrogen. It signals the end of fertile phase of woman's life. When it comes to effect is headaches and hot flush, the teeth become loosened, gum become resets, risk of cardiovascular diseases increases, there is backache, body and pelvic hair become thicker and darker, bone loses mass and become more fragile, hairs become thinner and loses luster, breast drops and flatten, nipples become smaller and flatten, skin and mucous membranes become drier, skin develops a rougher texture, abdomen loses some muscle tone, stress or urge incontinence may occur, and there may be vaginal dryness, itching, and shrinking. Now, the symptoms of menopause, natural history, and menstrual irregularity. Symptoms start and increase from 2 years prior to the final menstrual period, peak at 1 year following it, and return to normal after 5 years. It varies widely. Menstrual irregularity, there may be hot flush and sweat, sleep disturbances, vaginal dryness, urinary symptoms, mood changes, loss of libido, osteoporosis and cardiovascular diseases, and stroke risk increases. Menopause symptoms are usually self-limiting, usually last between 2 to 5 years, may last longer. Menstrual irregularity, length of the cycle can shorten or lengthen, often becomes more heavy. Hot flashes, sudden feeling of heat in the upper body spreading upwards and downwards with passive flushing of the skin followed by palpitation and sweating, so it lasts for a few minutes. And sleep disturbance, often due to night sweat, can lead to irritability, problem with short-term memory and concentration. Vaginal symptoms such as discomfort, dryness, dyspareunia, recurrent UTIs. Symptoms of atrophy may appear up to 10 years after the last LMP. Premature menopause, defined as a menopause before the age of 45, it may be a lot of causes, and the primary ovarian failure, the surgically induced menopause, radiation induced, chemotherapy induced, may be linked with smoking, lower socioeconomic group, BMI, family history. Refer any woman under 40. Prescribe HRT for osteoporosis prevention. Stop HRT at normal age of menopause. Primary ovarian failure may occur at any age, usually no cause is found. May be linked to chromosomal abnormalities, autoimmune disease, enzyme deficiencies, affect 1% of women less than 40, and 0.01% less than 30 years. 5 to 15% of women with primary ovarian failure may retain intermittent ovarian function for years, and spontaneous ovulation and pregnancy are possible. Now, management of menopause. There are 4 main important headings: the reassurance, education and lifestyle changes, HRT, and alternatives. Now, lifestyle changes may be hot fast and lightweight, maybe tackle with regular exercise, lighter clothing, sleep in a cooler room, stress management, and avoid triggers. Sleep disturbances, avoid exercise, adequate sleep, regular exercise, relaxation exercise, etc. And for cognitive symptoms, adequate sleep and exercise. Now, triggers may be spicy foods, caffeine, alcohol, smoking. Smoking and obesity linked with increase in hot flashes. Now, governing principles. Consideration of HRT should be part of overall strategy include lifestyle recommendation regarding diet, exercise, smoking cessations, and safe level of alcohol consumption for maintaining the health of peri and postmenopausal women. HRT should not be recommended without a clear indication for its use, as for example, symptoms or HRT must be individually tailored according to symptoms and the need for prevention, as well as personal and family results of relevant investigations and women's preference and expectations. There are no reasons to place mandatory limitations on duration of HRT. Whether or not to continue therapy should be decided at the decision of a well-informed woman and her health professionals dependent upon specific goals and objective estimation of ongoing benefits and risk. Doses should be titrated to the lowest effective dose. Lower doses of HRT that have been used previously may reduce symptoms sufficiently and maintain quality of life for many women. Counseling. Women taking HRT should have at least an annual consultation to include a physical examination, update of medical and family history, relevant laboratory and image investigations, a discussion on lifestyle and strategies to prevent or reduce chronic diseases. In cases of HRT, relief of menopausal symptoms, prevention of osteoporosis, and to maintain quality of life in menopausal years, special group of women to whom HRT should be prescribed. Premature ovarian failure, gonadal dysgenesis, surgical or radiation menopause. Benefits of HRT effective for treating vasomotor symptoms, treating urogenital symptoms, treating sleep or mood disorders if associated with flashes or night sweats, preventing osteoporosis, reducing risk of colon cancer, improves quality of life and sexual functions in symptomatic women. Now, what are the types of HRT? Now, when we prescribe HRT, we have to consider a few things, that women with uterus, women without uterus, or women with urogenital symptoms. With uterus, which can be combined, cyclical combined or continuous combined. Without uterus, we can use unopposed estrogen. And urogenital symptoms, we can use local estrogen. Now, what are the things we should consider? The HRT, when we give HRT, who? Women with menopausal syndrome. When? At the time of menopause or perimenopause. What? That is minimal dose with control symptoms, 0.5 milligram oral or 2.5 microgram transdermal. Transdermal estradiol in obesity, diabetes, hypertension, liver disease. Estrogen alone in our Marina, IUS, vaginal estradiol, evolone type of progesterones. How long? 3 to 5 years postmenopausal. Now, doses, estrogen depends upon symptom, bone protection, and progesterone, that is dose dependent, and it may be sequential or combined, and duration. Key points to be considered is primary use of any form of HRT is to control menopausal symptoms. HRT should only be prescribed for short-term relief of menopausal symptoms and prevention of osteoporosis. HRT should not be prescribed in the hope or expectation of any protection against arterial CVD or Alzheimer's disease. Oral or non-oral estrogen have different metabolic profiles that may impact on side effects and therapeutic risk, that is DVT. Combined estrogen progesterone preparations have different profile compared to estrogen alone. An increase in breast cancer risk is related to duration of use and also concurrent use of progesterone. The role of estrogen and or progesterone dose is unclear. Tibolone has significantly smaller risk of breast cancer compared to estrogen progesterone preparations. Data on HRT associated risks should not be extrapolated to women with premature menopause. The role of HRT, the natural menopausal symptoms, premature menopause, surgical menopause, other causes of estrogen deficiency under the age of 50 years, menopausal women at significant risk of osteoporotic fractures. Consider contraindication risks carefully. Now, preparations of HRT. There are varieties of HRT available in the market. There are natural estrogens from plants or animals. Estradiol valerate 1 to 2 milligram. Conjugated equine estrogens and estrone. And progesterone, methoxyprogesterone acetate 10 milligram. Didogestrone 10 milligram. Northestrone 1 milligram. Or norgestrel 0.15 milligram. What are the initial assessments? History, especially risk factor for CVD, history of breast cancer or thromboembolic phenomenon. BP, BMI, blood serum lipid, smoking habits, breast awareness screening program, cervical screening, lifestyle advices, and document discussions of risk. Systemic oral HRT, hormonal therapy. There may be cyclical combined that can be used in perimenopausal age group, have monthly withdrawal bleeds, continuous combined that is used if more than 1 year after past period or no bleed. If bleeding beyond 3 to 6 months, need further examinations. And unopposed estrogen only used if there is no uterus. And the contraindications of HRT, it is breast cancer, endometrial cancer, untreated endometrial hyperplasia, undiagnosed vaginal bleeding, thromboembolic disease, arterial disease, active thrombophlebitis, liver disease where LFT is not returned to normal, pregnancy and breastfeeding, stop 4 to 6 weeks prior to surgery and restart when fully mobile. Postmenopausal osteoporosis. Now, HRT is effective in preventing bone loss associated with menopause and decrease the incidence of all osteoporosis related fractures, including vertebral and hip fractures, even in women not at high risk of fractures. The initiation of HRT for sole purpose of prevention of fractures after the age of 60 years is not recommended. Continuation of HRT after the age of 60 years for the sole purpose of prevention of fracture should take into account the possible long-term effect of specific dose and method of administration of HRT compared to other proven non-hormonal therapies. The protective effect of HRT on bone mineral density declines after cessation of therapy at an unpredictable rate, although some degree of fracture protection may remain after cessation of HRT. If patient is still considered at risk for fractures after cessation of HRT, additional therapy with proven bone-sparing medications should be given. Now, risks of hormone therapy. Now, number 1, endometrial cancer, venous thromboembolic diseases. There is increased risk within 1 to 2 years after initiation of hormone therapy. Breast cancer, increased breast density with progesterone via proliferation of estrogen-dependent mammary tissue, making it more difficult to detect breast cancer early with mammogram. Ovarian cancer, if it is used more than 10 years of estrogen therapy, cerebrovascular accidents, lipid metabolism, and increased incidence of gallbladder disease has been observed following estrogen therapy due to rise in cholesterol in bile. These are the risks already I have talked to you: breast cancer, endometrial cancer, ovarian cancer, venous thromboembolism, stroke, coronary heart disease. Now, HRT prescribing fell by 50% between 2001 and 2005, probably due to Women's Health Initiative, which highlighted safety concerns. Risk of breast cancer returns to baseline after stopping for 5 years. Risk of ovarian cancer returns to baseline after stopping for few years. Stroke in older women have greater absolute risk of stroke on HRT. This seems to also be dose dependent. Coronary heart disease trials are on older women, lack of evidence for youngers. Overall, the risk of younger women is probably low given their already low baseline risk. Now, menopause hormone therapy. Now, what we can use is low dose OC pills, which can be used in menopausal transition period, premature ovarian failure till age of menopause, only estrogen in hysterectomized patient or in no uterus, estrogen progesterone combination, patient with uterus, patient with subtotal hysterectomy, patient with no uterus, patient past history of endometriosis. Commonly used regime is conjugated equinestrogen with methotrexate acetate 2.5 mg or conjugated equinestrogen with norethistone 1 to 5 mg. Conjugated equinestrogen with micronized progesterone or conjugated equinestrogen with digostestrone. It can be used cyclic, sequential, continuous, combined. Estradiol valeric 2 mg can also be used. Transdermal estrogen cream or digostestrone can be used. It decreases the CV and thrombosis risk. Vaginal estrogen cream or Evalon cream can be used. Tibolone 2.5 mg per day at same time to be started on or after menopause, but not beyond 60 years of age. The selective estrogen receptor modulator, raloxifene 60 mg per day, or benzodiazepine 20 mg or 40 mg per day. Non-oral hormonal therapy routes are transdermal, indicated in increased TG, increased CRP, migraine, diabetic control HRT, existing gallbladder diseases, and obesity. Other supplementations like calcium, vitamin D, bisphonate or in osteoporosis, alendronate 70 mg per week, 3.5 years drug-free period, to sit upright for 1 hour. Zoledronic acid 5 mg, infusion over 15 minutes, yearly once. Complementary alternative therapy, herbal. However, patient is not fit for hormone therapy or patient refuses hormone therapy, then they prescribed and they really giving equivalent good results. Now, quarterly contraindications: the active endometrial or breast cancer, undiagnosed uterine bleeding, severe liver disease, history of venous thromboembolism, acid. Relative contraindications are migraine, thromboembolitis, family history of carcinoma breast, uterine fibroids, endometriosis, gallbladder diseases. You should stop hormone therapy if migraine worsens, jaundice, there is increased BP, before any major surgery, 4 to 6 weeks before surgery. Maximum duration of hormone therapy, 3 to 5 years, up to 7 years, but better not to beyond 60 years of age. What are the indications of stopping hormone therapy? The general is to stop after 1 to 2 years to see if symptoms have gone. If they recur, can try lower dose or try different method. Stop HRT 4 to 6 weeks prior to major surgery. If started for early menopause, stop at the age of 50. Side effects of hormone therapy, there may be breast tenderness, nipple sensitivity, appetite rise or weight gain, calf cramps. Patient must review 6 months then annually. BP, breast, pelvic examinations. What are the medical alternatives? The tibolone, synthetic steroid with estrogenic, progesterogenic, and androgenic properties. Clonidine, alpha-2 agonist, which helps the vasomotor symptoms, useful for patients with history of breast cancer. Selective serotonin reuptake inhibitors can be used for vasomotor symptoms. Gabapentin reduces severity and frequency of hot flashes. Progestrogens may improve hot flash, but there are concerns about risks of breast cancer. Repellents, vaginal bioadhesive moisturizer. Clonidine enhances the effect of anxiolytics and should not be used with alcohol. Serotonin reuptake inhibitors is 60% compared to 30% for placebo. Gabapentin reduces frequency by 45% and severity by 54%. Natural herbs and remedies, there are phytoestrogens, red clover, structurally similar to estradiol. Efficacy data is insufficient. Black cohosh, buttercup family, flashes and other symptoms, data insufficient to date. Progesterone creams, and acupuncture. Now, plants use phytoestrogens as part of their natural defense to control female fertility to prevent overpopulation and overgrazing by herbivore animals. Phytoestrogens, there are phenolic and others. There are phenolics group, there is isoflavonoids, flavonoids, there is stilbenes and ligands. In flavonoids, there is flavones, flavonoids, and chalocones. And in isoflavonoids, there is isoflavones and comestans. In others, there is terpenes and sapones. Isoflavones most commonly found in soybeans, lentils, and chickpeas. Ligands found in beans, sprouts, alpha sprouts, sunflower seeds, and spinach and clovers. And comestans, most cereals, fruits, and vegetables. Isoflavones' effect on hot flashes is variable and inconsistent. Only modest and delayed improvement of symptoms could be expected by black cohosh and vitamin E. Now, hot flashes is substitutory soya nuts for non-soya proteins is in a diet and consumed 3 or 4 times throughout the day is associated with decrease in hot flashes and improved menopausal symptoms. 25 grams of soya protein and 101 grams of egg-like-on isoflavones is published in 2007 in Journal of Women's Health. Now, lifestyle interventions to improve quality of life during menopause. Now, lifestyle and behavioral modifications might not necessarily improve symptoms, but some may improve well-being and help women tolerate symptoms. Maintaining healthy weight. Women mostly request information about weight gain in menopause. Although menopause does not cause weight gain, there is evidence that weight gain can increase the severity of vasomotor symptoms. Breast cancer survivors with post-diagnosis weight gain has a greater risk of reporting hot flashes than women who did not gain weight. One study of 40 overweight obese women showed that 10% weight loss resulted in significant improvement in hot flashes, with a correlation between weight loss and reduction of hot flash frequency. Improve cooling through environmental control. Small core body temperature elevations can trigger vasomotor symptoms, so it makes sense to propose environmental and lifestyle changes that lower core body temperature or that prevent it from rising. Suggested changes include adjust clothing, dress materials like cotton cloth, wearing clothing made of natural fibers that breathe, avoid fit dress like jumpers, use a hand fan or electric fan as required, keeping cooler at night, lower the room temperature, put a cold pack under the pillow, turn the pillow over to cool side when feeling warm, use dual control electric blankets, use a bed fan that blows air between the seats, drinking cool liquids such as ice water. Avoiding triggers of vasomotor symptoms. Some metro class women can identify triggers for their vasomotor symptoms. Avoiding these triggers may help women to manage symptoms. Potential triggers include spicy foods, smoking. It has been reported as a risk factor for vasomotor symptoms. Smoking cessations may help to alleviate mild symptoms, but there are no clinical trials evaluating this intervention. Alcohol can trigger hot flashes, and some women find that their flashes are reduced when they avoid drinking alcohol. Several studies have investigated whether exercise improves hot flashes. Exercise may improve quality of life, cognitive functioning, depression, sleep patterns, fatigue, bone density, weight maintenance, and cardiovascular disease. Cognitive behavior therapy, group and individual cognitive behavior therapy are both effective at reducing the impact of vasomotor symptoms and at improving sleep and general well-being. This approach could potentially be used in conjunction with other therapies for menopausal symptoms. Yoga is very important, and there is mixed evidence that yoga is effective for management of vasomotor symptoms and sleep disturbance. Certain yoga poses are especially effective against hot flashes. Downward facing dog and legs upward. Paced breathing, slow, deep abdominal breathing for 15 minutes twice daily. It may reduce feeling of anxiety that can occur with hot flashes, but this practice does not reduce severity of hot flash. Which can be done. Deep abdominal breaths where you exhale breath is a longer count than your inhale breath. Relaxation exercise. Hypnosis. Hypnosis was more effective than the attention control comparison, and hypnosis also improved sleep and hot flash. Acupuncture. Small studies of acupuncture as a treatment of hot flash have shown mixed results. Magnetic therapy, reflexology, chiropractic interventions are also in the practice. Medical herbs with following active ingredients has shown promising results. Cinnamon, Wilfordi, Angelisa gigas, Fomis ambrosa, that contains cinnamic acid, cinnamon 45 microgram, S-methyl ester, Holmis ambrosa, 41.78 milligram, dextrim or decorational Angelica gigas, it is 45 milligram. Now, there is a product which is called ESTROGEN by Shield Healthcare. It contains it is a feminine balance formula with standard dose ESTROGEN 100 extract of Cinnamon wilfordi equivalent to cinnamic acid 2.57 microgram, Holmis ambrosa equivalent to synthesized methyl ester dried root, it is 0.129 milligram, Angelisa gigas equivalent to nodacaidin 1.0023 milligram. Cinnamic acid, a natural remedy used for hundreds of years in both Korea and China, has shown significant improvement in the quality of life for women dealing with the symptoms of pre, peri, and postmenopause. Now, it is documented that Angelica gigas is ultrafine Angelica gigas powder normalized ovarian hormone level and has anti-osteoporosis properties in ovarectomized rat, and it was published in 2012. Herbal formulations composed of combination of Cinnamon wilfordi and Holmis ambrosa tarcogenia and Angelica gigas nakai extract have been used for treating menopausal syndrome, and it was published in 2017. Perimenopause, menopause, and postmenopause. In all group, estrogen has a regulatory affinity to estrogen receptors. It upregulates the estrogen efficiency, the affinity to estrogen receptors in non-reproductive target organs, that is mesoendothelium, CNS, and bone. It reduces hot flush, night sweat, mood swing and insomnia, and bone mineral density. And it downregulates estrogen affinity to estrogen receptors in reproductive target organs, that is breast and endometrium. So there is no risk of cancer. The evidence suggests that it relieves symptoms of vaginal dryness, hot flush, mood swing, bone pain. Study concluded subjects on estrogen 100 groups had significant reduction from 10 out of 12 Copperman index symptoms. Evaluation of effectiveness and safety of estrogen 100 on perimenopausal women for 1 year. Osteocalcin starts with 6.02 nanogram per ml, and after 1 year, it comes down to 5.66 nanogram per ml. There is significant decrease. And there is alkaline phosphatase decrease. It is before start it was 73.35 in IU per liter, and after 1 year of use it goes down to 71.0 international unit per liter. The formal bone mineral density, before starting it was 0.746 plus minus 0.1 per centimeter square, and after 1 year of use there is significant increase in bone density, the 0.763 plus minus 0.13 gram per centimeter square. The study demonstrated improved bone health parameter significantly. So as a result, they can conclude estrogen for 12 weeks statistically significantly improved the quality of life 9 different symptoms improved: hot flush and night sweat, parenthesis, nervousness, melancholia, vertigo, fatigue, rheumatic pain, vaginal dryness of peri, and postmenopausal women. No adverse events were reported with estrogen 100. Estrogen 100 was found to be safe and effective herbal formulation that can improve women's quality of life and various menopausal symptoms. Thank you very much for your patient listening.
Thank you so much, sir, for giving all the detailed information regarding menopause and its management. So let me check questions if we have any from delegates. Give me 1 minute, sir.
Yeah.
So, sir, first question is how many women do you receive as a case of menopause who also have osteoporosis? And if they have osteoporosis, how much of vitamin D do you recommend for them?
Vitamin?
D.
Vitamin D.
Yeah.
Okay. Okay. Usually we start with vitamin D, 60,000 international unit weekly.
Okay, sir.
Yeah.
And the second question is can menopause cause any kind of digestive problems or change in bowel movements?
Bowel movement.
Yes, sir.
Actually, not directly.
Okay.
It is not directly, and because of aging, they used to have some bowel problem along with liver problem and gaseous problem. There's so many factors that comes together actually, but not directly from menopause.
Okay, sir. Then, sir, how can a woman deal with anger management occurring during this menopause
Yes,
age?
yes, that is why counseling is very important and reassurance is very important from the physician's point of view. It's our prime duty or prime importance to counsel those ladies who are very anxious or who are very nervous about their upcoming symptoms of menopause, because all are
Yes.
very aware that I am going to have these symptoms or I am going to have this problem very soon.
Yes.
So reassurance, lifestyle modification is a very essential and crucial part in regarding the management of this group of women. And
Okay.
we should very delicately we should deal with these symptoms.
Okay, sir. So I cannot find any more questions. So thank you for giving
Yeah.
all the answers to
Thank
this.
you.
Nishanji Bharat here. Sorry to interrupt you.
Yeah.
Sir, I have a doubt. With your permission, can I ask you, sir?
Yeah.
Yes.
Yeah, from my side. Sir, while treating hot flushes in pre and postmenopausal women, so if you wanted to add, for example, calcium, how much you recommend daily basis, sir? What is the strength?
Calcium.
Yes, sir.
500 milligram is enough daily.
It's daily. It's a one time, sir, or twice daily?
Yes, yes.
Twice daily.
Yes, yes.
Okay, sir. Fine, sir. Fine. Thank you, sir.
Thank you.
Okay, sir. So thank you so much for
Thank you. Thank you very much.
participating in the Shield Connect. And sir, we would like to have more sessions with you on our platform, sir. Thank you so much.
Thank you, Mr. Nishant. Thank you, sir. Thank you, Rajesh
Thank
ji.
you.
Thank you, Deepak.
Bye.
Have a nice evening,
Thank
everyone.
you. Thank you, sir.